Everyone. Welcome to this webinar of ISU. I welcome you all for this webinar. It's a very interesting webinar. Dr. Cornerstone Wann from Shillong is the convener for this webinar. Again, lost the connection. Just a second. Lost the connection. Yeah. So I welcome ma'am, Sujata Patwardhan ma'am, who is the chairman of ISU for this webinar. Madam is here. And we are supposed to have Dr. Rajiv TP, President USI, and Dr. Uttam Mite, Honorary Secretary USI. I think they are busy in this boss meeting in Manchester. The tradition is usually we start the meeting with opening remarks from our USI President and USI Secretary. We also have Dr. Rohit Upadhyay, who is the board member of ISU for this meeting. Now I request Dr. Rohit.
Dr.
Hello,
Corner.
Dr. Yeah, would you like? Yeah,
yes,
you
am I audible?
can start. You can say.
I think I'm
Yes,
audible.
yes.
So, Dr.
Yes.
Cornerstone is Associate Professor at Northeast Indira Gandhi Institute of Regional Health and Medical Sciences. I think it is an autonomous institute funded by government, and they will be speaking about their experience of obstetric fistulas in the northeastern part of the country. And he will be supported by his the colleagues of the department. So I will request Dr. Cornerstone to start this meeting.
Thank you, everyone. Thank you for the USI for allowing us to share this platform, and thank you especially Dr. Sujata, who has been very kind to let me have these sessions. The most important thing before I carry on is when I came back to the Northeast, we realized that we have so many cases of obstetrics urogenital fistula. And when I look back at all the morbidity and mortality of maternity in Indian data, we found that actually we have a lot of cases from the Northeast. So we have many cases. Being a central government institute, we cater to almost all the states of the Northeast. And Dr. Sailo has vast experience with it. And before we proceed, I would like Dr. Wansa to introduce us about the topic, about the maternity situation in our state and also in the Northeast, but even though there's a limited data. And she will also talk a little bit of the prevalence of obstetrics fistula. And Dr. Wansa, she is Wansalan Shullai. She is an associate professor in the Department of Obstetrics and Gynecology here in NEIGRIHMS in Shillong since 2018. She is a graduate from JIPMA Pondicherry. She has vast clinical experience and she has so many research projects running under the ICMR and other part funded by the institution. So Dr. Wansa will talk to us about the current scenario of the maternity care in Northeast and especially with it focus to Meghalaya and also a little bit about the obstetrics fistula. Over to you, Dr. Wansa.
A very good evening. Are my slides visible?
Yes.
Yes.
Okay. At the outset, I would like to thank Dr. Wann for your kind introduction and the Indian School of Urology for giving me this kind opportunity. Just a minute, please. Okay. The topic that has been given to me today is the current scenario of maternity care and obstetric urogenital fistula in Northeast India. So what is the relevance of this topic? Why talk about OUF? OUF, despite its devastating impact on the lives of girls and women, obstetric fistula is still largely neglected in the developing world. It has remained a hidden condition because it affects some of the most marginalized members of the population, the poor, the young, often illiterate girls, and women in remote regions of the world. Obstetric urogenital fistula is a marker of severe maternal morbidity and an indicator of the quality of maternal healthcare delivery, thereby making this topic very, very relevant. And 2 million young women, as per data, live with untreated OUF in Asia and Africa alone. So looking at the estimates globally, the WHO estimates that between 50,000 to 1 lakh women worldwide develop obstetric fistula annually. Now this translates to 3.5 million women currently living with urogenital fistula. Now closer home in India, the estimates is at 1.5% as per the DLHS 3. However, these estimates are generally based on self-reporting, personal communication with surgeons, studies by advocacy groups, and reviews of hospital services in which the relevant denominators are unknown or unreported. And of course, there is a scarcity of studies with regards to estimates. So maybe this is one area of research that we do have to work on, especially with audits of these. Very sorry, just... Okay. So as per the DLHS 3, when we look at the different states in India, the state with the highest percentage of obstetric fistula is the state of Assam, which is in the northeastern part of the country. Now, this is very interesting because Assam also has the highest maternal mortality ratio in the country. Now, if we compare this percentage along with states like Kerala or Tamil Nadu, which have a more robust maternal healthcare services in place, we can see that this is a definite significant number. Now, looking at the other states, now looking at Meghalaya or, for example, the state of Mizoram and the other northeastern states like Arunachal and Tripura, these also reflect about 0.2 to 0.7%. So the question therefore arises whether these cases are actually being underreported in the other northeastern states apart from Assam. Now, looking at the etiology of OUF, so the most common etiology, of course, is prolonged and obstructed labor, instrumental deliveries, multiple and repeat cesarean sections, ruptured uterus, and of course, cesarean hysterectomies, either because of ruptured uterus or in today's day and age because of the increased incidence of adherent placentas. So those can also predispose to OUFs. Okay. So when we look at the consequences of these obstetric urogenital fistula, it's not only physical, it goes beyond the physical realm. Women who develop a fistula during childbirth frequently face stigma, social ostracism, and isolation due to the odor of urine. Given this high level of stigma and isolation, women with OUF report high rates of general mental health impairment, depression, low self-esteem, and low quality of life. So it's not only the physical, it is the social, psychological, and even economic consequences, because these are the women, especially when we look at daily wage earners, they're the ones, it can even affect their daily livelihood. So the consequences are, of course, extremes. Now, looking at maternal health in the state of Meghalaya, where do we stand? The main cause of morbidity among the women of reproductive age group within Meghalaya are pregnancy and childbirth related complications. Now, we have various targets set by the National Health Policy at the national level. And as we are all aware, we have global targets set as per the Sustainable Developmental Goals. Now, looking at this table here, what is very interesting is that in the state of Meghalaya, the institutional delivery is only at 58.1%. This is as per the 5th National Family Health Survey, as opposed to the target set at 90% by the National Health Policy. So we are still a very long way to achieve that target. Now, looking at the contraceptive method, we are just at 27% as opposed to 90%. And looking at the total fertility rate, again, our state has a very high total fertility rate. Now, you must be wondering, why have I projected these numbers here? Reason being, when we look at obstetric fistulas, when we look at literature, patients who come at a later stage, prolonged labor, obstructed labor, are more prone to have developed these fistulas. Now again, lack of contraceptive method would mean higher order pregnancies, more number of children, and lack of spacing between two such pregnancy, again, a predisposing factor for fistulas. And of course, it also has a lot of socio-economic implications. More number of children, more poverty, and these children again will go on to not have an education, and these young girls who are born of such mothers, so it's a vicious cycle. So therefore, especially the institutional delivery being at only 58.1% is a very significant number. So coming to the other health care indicators in the state of Meghalaya, now looking at antenatal care, which again is a very important part, we have the percentage who actually receive antenatal care is at 83%. Right? These are patients in total, irrespective of the number. But if you look at the minimum requirement as set by the WHO at 4, that drastically comes down to 54%. So again, there's a lot of question that why is it that patients do come for one visit and thereafter they're lost to follow up. And again, as we can see, and again going to stress on this, those who are actually delivering a healthcare facility is only at 58.5%. Now, again, there are certain issues which are very prevalent in the northeastern part of India, which may not be as relevant in the other parts of the country. Teenage pregnancies. So we have data suggesting that girls as young as 15 years of age, 15 to 7 is at 5.2%, and girls at 19 years of age, the percentage of them who have begun childbearing is again 21.8%, a very significant number. And this also translates. So most of these girls will be school dropouts or maybe not even educated. They're illiterate. So that stands at 29%. Again, very important numbers. So looking at the birth order, like I stressed initially, the total fertility rate in this part of the country is very high. And the birth order, as we can see, 4 or more is at 85%. So that again is a very significant number. So what are the gaps in maternal health care? On a global scale, the continued incidence of obstetric fistula in low-resource settings is one of the most visible indicators of the enormous gaps in maternal care between the developed and developing country. So we are all aware with the Sustainable Development Goal number 3, and target 3.8 says achieve universal health coverage. Now looking at the National Family Health Survey, the 5th National Family Health Survey status in Meghalaya, the number of percentage of women covered by any insurance in total is actually just at 66%. So this will explain why people prefer home deliveries to institutional deliveries. Now, our colleagues from the Department of Community Medicine had published an original article where they looked at the factors affecting place of delivery in Meghalaya. Now, while it is very heartening to see the government both at the national and the state level, they have all these various schemes to push for institutional deliveries. We have the JSY, the JSSK, the MMBS. However, despite all these measures, the institutional delivery is still just at 58%. And some of these factors, as per this original article, could be lack of healthcare facilities or infrastructure, unskilled caregiver, terrain, geographical reason is one of the major problems here, illiteracy, and of course, poverty. So again, now when we talk about fistulas, one very important aspect is also diagnosing it. I think my colleagues will be talking about that a bit later. So postnatal care, not only antenatal and intrapartum care, but percentage of women with postnatal checkup total is only at 69%. Again, a very significant number. Right? And we also had a review article published about a decade back, which actually list out these same risk factors, right? Age lesser than, so teenage pregnancies, delivery at home, low levels of maternal education, poor contraceptive utilization, low rates of antenatal care. Okay, these are also the risk factors that contribute to obstetric urogenital fistulas. So to conclude, early childbearing age, high order pregnancy, poverty, lack of access to contraception, perinatal care, and emergency obstetric services are primary factors contributing to obstructed labor and thereafter subsequent fistulas. So given the continuing presence of this devastating maternal health morbidity, the impact of obstetric fistula on the lives of women warrants close inspection. So the take-home message is obstetric urogenital fistula in the Northeast is higher than the rest of the country. And some of the reasons could be because of the poor institutional delivery. Therefore, creating awareness about the importance of institutional delivery is paramount. Better healthcare facilities, need for a skilled caregiver. And the skilled caregiver should not only be at the antenatal and intrapartum period, but of course, the continuum of maternal healthcare services should also be continued in the postpartum visits, where in case there's a fistula, it can be diagnosed and treated early. Need for trained surgeon managing urogenital fistula and need for more research in this area to mitigate the problem. Thank you so much.
Thank you, Dr. Wansalan. And shall we proceed to the next speaker?
Can I ask a question in short? Yeah, excellent talk, Dr. Wansa. And what is the average age where a female child gets married in Meghalaya?
So, ma'am, most of these are out of marriage, right? So we have a lot of POXO cases. So anyone who comes below the years of 18 years. So right now in my ward, I have a couple of girls who are just 16 years, ma'am. And you know what's very interesting? I have a couple of patients where the mother has come to deliver the 10th or 11th child, and the attendant is actually the firstborn. So we do have such incidences of very high, order pregnancy where when the mother comes and deliver, her attendant's actually the firstborn. The firstborn's already crossed 18 years and she's come to deliver her 12 or 13 child. So such problems are, definitely relevant in this part of the country. Maybe we don't see them as often in the rest of the country.
Yeah. Okay. Thanks a lot. Thank you.
Ma'am.
Yeah. Can I ask a doubt?
Yes, sir. There's a lot of echo, sir, from your side.
You are having an echo. You can put your video off, maybe, Surya.
Yeah. Oh, yeah. I think still there is some echo. Ma'am, that was an excellent talk.
Thank you so much, sir.
Yeah, you can put it in the chat box. She can answer it later on.
Sure. Okay, we'll go ahead.
Shall we go on to our next speaker?
Yes.
Okay. Next speaker is Dr. Stephen Sailo. He is head of Department of Urology here in NEIGRIHMS in Shillong. He'll be talking about treating about urogenital fistula, which is an experience from the institution. And Dr. Sailo is a graduate. He did both his undergraduate, postgraduate, and super specialty from CMC Shillong. And he's been working as a urologist from the year 2006. And he has a vast experience and has publication and has multiple presentations in the different conferences about urogenital fistula, including obstetric fistula. So we'll be talking about what is his experience here in Meghalaya. Over to you, Dr. Sailo.
Siang mati na. Hmm?
Oh. Mic.
Good evening, Doctor.
Good evening.
I'm audible.
Yes, yes.
Oh, actually, I'd like to thank Professor Sujata, Professor Surya Prakash, Dr. Rohit, Dr. Upadhyay, and Dr. Cornerstone to speak something which is very close to my heart. Actually, when I left CMC Vellore to join NEIGRIHMS in 2006, the first 3 or 4 patients are all fistulas. So I'm very grateful to each of you for attending this webinar. I like to thank Dr. Wansa also for going through the urogenital fistula so vividly. So I'll just omit these slides. So basically, NEIGRIHMS was established in 1998 to provide tertiary care to this Northeast India. So I joined NEIGRIHMS in 2006. I'm very happy to say that the Department of Urology was the first to start operation in this hospital. So since my first few patients are all fistula patients, I developed interest to collect all their data. So I collect all the data for the first 8 years with emphasis on the etiology, the type of the fistula, and the results of treatment. So this study is a case series, prospective and hospital-based study. Basically, all those patients who attended the Department of Urology for the first 8 years were included in this study. So after proper examination, and we did hemoglobin, TLC, DLC, kidney function test, random blood sugar, urine analysis. At that time, after ultrasound, we did intravenous urogram in all cases to rule out ureterovaginal fistula. Some patients develop vesical fistula, which are radiolucent, so it cannot be seen clearly with KUB X-ray. So some of them underwent non-contrast CT scan for better evaluation of the bladder stones. Cystoscopy and dye tests were done to find out the site, size, and the number of fistula, as it would affect the timing and the route of surgery. In case of ureterovaginal fistula, we did percutaneous nephrostomy to preserve kidney function and to prevent urinary tract leakage. So we divided fistula into 3 groups. Fistulas due to obstetric labor, we call them obstetric fistula. Fistulas due to hysterectomy, gynecological fistula, and fistula due to cancer, malignant fistula. So we repair all obstetric fistulas at least 3 months after the fistulas formed. Gynecological fistulas were repaired around 4 to 6 weeks after fistula formation. The approach to the VVF repair was based on the location of the fistula, size, and proximity of the uteric orifice to the fistula. All supratrigonal fistulas, fistulas larger than 3 centimeters, fistulas adjacent to uteric orifice were repaired by abdominal approach or corner technique. The rest of the fistulas, VVF, were repaired using vaginal approach. One patient had a big fistula which need combined abdominal and vaginal approach. All repairs, either abdominal or vaginal, were reinforced with intervention flaps, either omentum or Marcier's flap. In both approaches, ureters were catheterized using either ureteric catheters or infant feeding tubes. Foley's ureteral catheter was used for bladder drainage in all cases. Suprapubic catheter was used only in a few cases. After the repair at that time, the catheters were kept for 21 days. Patients were considered to be cured if they had no urinary incontinence and voided normally. If they had urinary incontinence, pelvic examination and cystoscopy was done to find out the cause of the incontinence. It could be a recurrent fistula or it could be a stress incontinence. Patients were advised to avoid sexual intercourse for 3 months. Patients were followed at 1 month, 3 months, and every 6 months for 2 years. So during this study, we had total number of patients, 52 patients. Obstructed fistula was 37, 71%. And 13 patients developed fistula following hysterectomy. And there are 2 patients who had CS cervix and developed fistula. The most common fistula we saw was VVF, which is 41%. 4 patients developed ureterovaginal fistula. We had 3 cases of combined VVF with rectovesical fistula. There are 2 cases of uterovesical fistula, 2 cases of urethrovaginal fistula. So a total of 52 patients were treated during the study. The mean age of the patients from obstetric fistula was 34 years, 42 for the gynecologic fistula, and malignant fistula, there are 43 and 54 years. The mean duration, because at that time there are no urologists in Meghalaya, Mizoram, Tripura, Arunachal. The duration was very long. The mean duration for obstetric fistula before repair was almost 6 years, and gynecological fistula 2.6 years. And as we said, the etiology of the obstetric fistula, maximum number was related to obstetric care, poor obstetric care. 24 developed due to prolonged labor, and LSCS due to obstructed labor. Then 3 developed fistula because of laparotomy following ruptured uterus. 2 developed forceps, then for IUD, and 1 patient developed uterovesical fistula for dilatation and evacuation following incomplete abortion. The VVF, the most common, we had 41. The most common cause was obstructed labor, then LSCS because of obstructed labor, subtotal hysterectomy, and 11 patients developed following abdominal hysterectomy. 10 were open, 1 was laparoscopic. So we had ureterovaginal fistula, 4 of them. 2 were following abdominal hysterectomy, 1 following laparoscopic, 1 was due to cervical cancer. So the combined VVF and RVF, 2 were due to obstructed labor, 1 was following radical hysterectomy. Uterovesical fistula, 1 was following dilatation and evacuation. The combined VVF and uterovesical fistula, 1 was for ruptured uterus. Uterovesical fistula, 2 of them were due to obstructed labor. So the treatment, the VVF, 19 we repaired by O'Connor technique, out of which 17 we have successful, 2 were failures. Vaginal approach, we did 9, out of which 8 were successful, there were 1 failure. Combined approach, that was successful. Unfortunately, during this time, there are 3 patients who came with severe dysuria while having VVF. They had bladder stones, so I removed the bladder stones, but they never came back for repair of the VVF. So this is one of the patients who had a big bladder stone with VVF. I removed the stone, but the patient never came back for repair. I called him to come back after 6 weeks for repair of the fistula, but all 3 of them never came back for the repair of the fistula. So the ureterovaginal fistula, 2 of them underwent ureteroneocystostomy, which was successful. There were 2 patients who underwent surgery for VVF with RVF. One of them I did the diversion colostomy, then repaired the fistula, and then closed the colostomy. One patient had only the leakage of fecal matter only during diarrhea. That one I did without diversion colostomy. Ureterovaginal fistula and VVF, we did the O'Connor repair and hysterectomy, but this patient had a recurrence. Ureterovaginal fistula, 1 was repaired, which was successful. So we treated only, out of 52, only 35 patients were treated during the study, out of which there were 4 failures, so we had a success rate of 31. There were 4 failures during the study. 1 was VVF with ureterovaginal fistula, and 1 patient developed hypertension in the post-op on the 2nd day. They advised for ultrasound, the bladder was clamped, and 1 patient developed hematoma where I took the Marcius flap. So the immediate complication, there was 1 case of gross hematoma from Marcius flap where I took the flap, so that patient has to be explored. Then the 1 patient gross hematuria which needed bladder wash, and there 1 patient who had the abdominal leak from the abdominal wound, which healed with conservative management. Then in the follow-up, so we used to follow up at 1 month, then every 3 months for 2 times, then every 6 months, then yearly. 2 patients complained that they had stress incontinence. 1 patient improved with casual exercise. The other one, we did a urethral sling using rectus sheath. 1 patient developed bladder stone, which we removed using laser at that time. So in conclusion, majority, 71% of the fistula were obstetric origin. Most patients were treated very late. Only out of 52, only 35 underwent repair. The rest did not come for repair. In spite of our hospital being a government hospital, most of the treatment is free. So the success rate was 88.6, and all the repairs were done by open surgery. So this is one of our patients who underwent surgery, and I thank you, every one of you, for your patient listening. Thank you very much.
Do you have some questions?
Actually, one question I have put in the chat box. Actually, we have seen patients in which trigon, bladder neck, urethra, all is involved in obstetric fistulas. So I am sure you people must have also seen such patients. What do you do in such cases?
Third, actually there, we have to repair. The problem is whether to do the sling at the same time or a different setting. So usually in my practice, I didn't do any urine diversion at all. So try to repair it, but the problem is that most likely they'll develop incontinence because of the bladder neck. So then you have, my own feeling is to do the urethral sling after the repair at 2 separate sittings.
Actually, these patients are generally from very poor background.
Yes,
So
yes.
that is a double whammy.
Mm.
They are a double whammy. That is the problem.
Yes, sir. Very much. Ma'am, I didn't see any case of TB so far.
Ma'am, I have seen. Recently, I have seen a case
I
of
have not seen, ma'am. I didn't see.
spontaneous VVF, which was diagnosed as a case of tuberculosis. Recently. Spontaneous VVF.
Okay. Is it? Yeah, we had
Sailo?
tuberculosis where the bladder was totally destroyed. So I have seen 2 cases. So there was no question of repair. So we had to divert and we did an ileal conduit. So I had a little different approach to repairs of VVF, and I thought that either we repair them, and there are cases where we can't repair and we have to think of diversion as a method of surgery.
Okay,
Anyway,
ma'am.
I have a lot of coughs, so I'll stop speaking. Thanks.
Ma'am, thank you. Thank you very much.
Dr. Sailo, that was an excellent presentation. I'm sorry, again echoing. Sorry, I'll put my question in the chat box.
You can write it in your chat box.
Yeah.
Okay, we'll go to the last presentation. That is by me. So okay, can everyone see my slide?
Yes.
You can go.
Okay.
Thank you.
Okay, so as you can see, the obstetrics fistula is actually one of the most common fistula that we see in the Northeast, which is much more common than in the rest of the country. So this reflects on the mortality and also the low development in the Northeast. But this actually also counter with the problem, also not counter meaning the addition to this, because we have the problem of the people who will repair this is actually very less. So who are the people who will repair this? So I'm actually talking from NEIGRIHMS from Shillong. This is from the Institute of NEIGRIHMS. So the thing is, most of the repair are done by urologists and also a few by the general surgeons and the gynecologists. So how many urologists do we have? At present, according to the urologists who are registered with the USI, this is at present. In Assam, we have the maximum number of them. In Manipur, 13, followed by Manipur and Nagaland. And the rest of us actually, Tripura, Meghalaya, Mizoram, Arunachal, Sikkim, we have very few urologists, only one which will cater to the whole entire state. Dr. Sailo was here in Meghalaya for a long time alone. So where are these institutions located? Most of them are actually in the where are these urologists practicing? Most of them are in the central government and medical colleges, and also in private institutions. There are other institutes that also teach MCH in urology is like Regional Institute of Medical Science in Imphal, and also recently in Assam. And we are planning to start in NEIGRIHMS also the course in MCH. So there is a need for urologists actually to take care of all these patients. But do we actually need to do it? We will go on later. What is actually the thing that we need to do in the Northeast? So going to what are the current practice that we do in Meghalaya and also in the most part of the Northeast? Most of the obstetric fistulas being repaired either transvaginal or open transabdomen, either by the urologist, the general surgeon, or the gynecologist themselves. However, in Assam, there are much more. There are more facilities of laparoscopy and also for robotic repair. So most of the time, the vesicovaginal fistula are being repaired by transvaginal and also by transabdominal. Here in our institute, initially we had a lot of transabdominal repair, but slowly we started shifting to transvaginal repair, both even for subtrigonal and supratrigonal. Remember, this is just for pure vesicovaginal fistula. So the repair that we do can be done in the immediate setting when the obstetrician identify the condition and repair wherever feasible. But sometimes when the fistula is big, when the risk of necrosis and tension repair is there, we tend to avoid doing the primary repair. Delay repair, we do it when we miss it on table or when there's a large fistula. We wait usually for 6 weeks to 12 weeks for the transvaginal repair and about 3 months before we plan to do a transabdominal repair. So the type of repair, usually what we do is either Lasco repair or the flap repair using marshes or the flaps. The transabdominal repair we use when there's a large BVF and especially when we do it when we plan to reimplant the ureters. Like so I say, most of the time we do transabdominal repair use O'Connor's technique. But however, in days where facilities are available, especially in Guwahati, and also they have started even in Imphal and also in Nagaland, these transabdominal approach are being replaced by laparoscopy and recently by robotic technique. The outcome, the transvaginal approach is better than the transabdominal approach. This is actually from before, and we've also noticed it even in our study, even in our institution. Though we don't have much of the minimally invasive surgery, but then the transvaginal approach is still superior than the transabdominal minimally invasive approach. And what about the early or the late repair? We have no data to present at present. And however, the WHO still recommend a transvaginal repair for all straightforward vesicovaginal fistula. The ureterovaginal fistula, as I said, what we do is as Wansalan said, we have seen this especially when we do a placenta previa or perpetua or even uterine ruptures. And also sometimes when there's a large BVF, it encroaches into the uteric orifice and also present as a uterovaginal fistula. Most of the time we do is a reimplant and then we do the treatment transabdominal. And the DG stenting, we do it when we identify it early. And sometime when the gynecologist or the obstetrician diagnose the case as a very severe cases or bad cases, we preemptively put the DG stenting to either to identify or to repair the uteric injury. And patient who present late or who develop ureteroperitoneal fistula, we put a nephrostomy and then we reimplant the ureter later. The ureterovaginal fistula, this is actually quite a terrible one. We have very few cases though. So I had seen one and I have done 2 repairs, but then both these patients end up with incontinence and they haven't come up for follow-up. But we had, so with Sir's, Dr. Sailo's experience, he has done some repair. We have seen it actually more common in patients who had instrumental delivery, either forceps or suction cup. And most of the time we have to do a transvaginal repair. And besides incontinence, stress incontinence is also another important complications. And about 20% of the patient develop stenosis. They require regular dilatation. And uterovesical fistula, we've encountered some of them. They're seen commonly during C-section, But most of the time when they come before, when they have lactational amenorrhea, we may not see this classical signs of Yusuf syndrome. But patient do present, the chronic patient do present with cyclical hematuria. The treatments actually we've always done is actually open. However, in Assam, they still do lab and robotic as well. A complex urogenital fistula, we've seen in large fistula, we have seen plenty of them. And most of the time we do either transabdominal or we combine both the transabdominal and the transvaginal repair. And those people we cannot do, we send them often to other centers which do these repairs often, either in All India Institute or in the other places. We do manage conservatively some patient who have a small fistula, less than 5 millimeter. We put a Foley's catheter, we keep it at least for about 6 weeks. And some patient we keep surgical sealant when we identify them early. And patients, some of them we inject plasma-rich concentrate. And ureteric stents, however, we have found out they don't help us much with the small, even with the small VVF. Endoscopic management, we have done a few of them, for which we have cauterized the edges of the fistula, either with the cautery or even with the laser. And we have had 1 or 2 cases only. However, the future may be tissue engineer, but still is under study. There are studies which show that we can use the amniotic membrane from the fetus itself. What about the future practice in the Northeast? We've seen most of our repair are open surgery and transvaginal repair. However, transvaginal repair is still the gold standard for a straightforward vesicovaginal fistula. Minimal invasive surgery should be made available. Most of us in the Northeast, we have very few access to the laparoscopic surgery. So I think it could be made available. And robotic surgery is also feasible for at least for each state capital. And it can be done in combination with general surgery or gynecology and all that. And the urologists and other surgeons should also be trained to be able to perform these fistula repair, both laparoscopy and robotically. The take-home message is from what we have seen is actually the first operation or the first repair is often the good, offers a good outcome. The outcome is better when we treat these patients by an experienced fistula surgeon. And also we need to train more surgeons and gynecologists in our region, because even the trainee of urology, they can be trained to repair fistulas, because this is one of the most conditions that we see here in the Northeast. So another important thing is patient care, and the patient and the caregiver should be made aware of the disease condition, and they should be taught about delaying the age of the first pregnancy. We have seen here what Wansalan has showed us, that we have a very common case of teenage pregnancy. We should create awareness about that. And we should train the people who deliver these ladies, these women, and also we should avoid the traditional practices of home delivery by an untrained caretaker. And also we should train people to identify these cases before they develop a prolonged labor and refer them to a appropriate center. The most important thing is obstetric fistula is curable, but most of all, it is preventable. So with the development of education, with the elevation of poverty, and also with awareness, obstetric fistula can actually be prevented. And this will reflect, hopefully, in the near future as we come back to the Northeast tour. Thank you.
That was a great talk, Dr. Cornerstone. I like the last statement. Obstetric fistula is curable, but most of it is preventable. So,
yeah, it was a nice talk from your institute, both Sailo, Cornerstone, and Dr. Wansalan. We really enjoyed speaking to you, and I think there's no need to feel bad that you don't have a robot to repair a VVF. I think what you can do vaginally is much more easier and less costly, and I think if you can deliver it at a lower cost, there's no need to indulge in a robot just because others are doing it. There are certain
Very true.
indications definitely where I think laparoscopy and robotic have a play, but not necessarily. it's not compulsory that you need a robot to perform and excel in vesicovaginal surgery. Anyway, we really enjoyed all your talks and thankful, and I hand over it to Rohit and Surya to conclude.
Yeah, yeah. Thank you, ma'am. Yeah, I have few questions. Maybe we can have some discussion. Dr. Cornerstone,
Yes, sir.
you're talking about obstetric fistulas. What is your like the way of difference in managing iatrogenic and obstetric fistulas? I'm talking about the operative procedure. In obstetric fistula, it's mandatory to wait for at least 3 months for the demarcation, but we don't follow that in all iatrogenic fistulas. I do operate immediately when we identify the fistula following post-hysterectomy. What is your practice? And another question is, do you excise the fistula edges because they're all because of ischemic injury? Do you excise the fistula, which is not a routine in iatrogenic fistulas?
Sir, obstructive fistula, usually we wait for at least 3 months for the inflammation and the edema to subside.
Yes,
So
yes.
usually I wait that long. But the other, that like fistula following hysterectomy, don't have to wait that long because there is not that much of edema and what do you call inflammation. Practically, I never excise the edge of the fistula. When I do it even trans-abdominal or because the hard textbook will say that you have to excise the fistula like O corner. But practically, I never excise in my practice. I never. And that third thing, sir, what even Bobby was posting in the chat box, somehow, no, I have never been able to convince any of my patients to undergo ileal conduit. Somehow they say they prefer to leak from below than ileal conduit. I'm not so far. I am not able to convince a single patient to undergo diversion. Somehow I don't know why they're not willing. They prefer to leak from below than having ileal conduit. That's my experience so far.
Can I say something?
Yes, sir.
Regarding robot, I will say that these patients require treatment. They are generally from very poor background or middle class or lower class. They need treatment. They don't need robotic treatment. So it's perfectly fine if you don't have robot.
Very true, sir.
Yeah.
And secondly, as Sir was saying that none of his patients have been convinced with ileal diversion, the simple reason is that these patients are from such lower backgrounds because generally these patients who come with bladder neck, urethra, trigonal involvement, they are being treated by care providers who are not even trained in basic forceps delivery. So they are coming from very poor background, and for them it is perfectly fine even if they leak from below because a disfigurement of their anterior abdominal wall with an added cost is a strict no for them. So they accept their fate. It's not that they are not willing; they accept their fate.
Okay, thank you.
So, and regarding corners, it was a very good presentation. And I think if you don't have robot, okay, you will feel sorry that you are not going to do a pyeloplasty or CA prostate. But regarding VVF, I think transvaginal surgery, I think is
Yes, sir.
inch better than robot rather than inferior to it.
Thank you.
That is perfectly fine.
I
Thank
think that things will improve, and very soon they start doing minimally
Yes.
invasive procedure.
Don't
But
worry. Actually, robot will come in Ayushman, and all the government hospitals will be having Ayush robot
yeah,
very soon in
that
next
will
5
be
to
a
10 years.
boon to everybody. But surprisingly, Dr. Cornerstone, the slide you have shown about the urologists in Northeast, it's
Yes, sir.
surprising. There's such a great scarcity of urologists in your place, whereas in other cities, especially in South, we are flooded with urologists.
Don't
So,
don't 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 think so. 10 years. Just wait 10 years. Now there will be so many urologists. Even Northeast will be feeling a flood of urologists.
Really?
Okay.
Just wait for 5 to 10 years. Not more than
So
that. 5
I would
years
like
is
to
enough.
I would like to ask the house any input from Assam. Dr. Chakravarti is there. Can he give some input?
Yeah. So,
Ajay, one last question. Anybody having a personal experience of treating this small fistulas conservative?
Yes, sir. Actually,
yeah.
during the study, two patients, while waiting for the surgery, the fistula got cured. Two of them, very small ones.
I have seen spontaneous healing of UVF, the uretrovesical fistulas, but I have yet to see any
VVF, I
VVF.
saw two of them. And
Okay, it's great.
one patient which I did was small fistula. I put the uteric catheter, and the edges I just cauterized with holmium laser. Then somehow it cured. That was one experience recently.
And I tell you, I tried the same thing with cautery, and that hole got bigger, bigger, and I have to do it after some time.
Okay.
So it can run both ways. That is the problem.
Okay, thank you.
Rohit, it can be done. I also have done successfully, but it has to be really small fistula. Just
Yes.
admitting a guide wire or if maybe 5 French catheter, you can cauterize it and
Yes,
got
it heals.
maybe 5 to 6
I also
cases
saw
managed like
two of them.
yes, yes.
Thank you very much, sir.
Thank
you,
you.
Dr.
Thank you.
Sujata.
So to tell you all of you that Dr. Cornerstone has got a very illustrious career. He did all his education from CMC Vellore, prestigious CMC Vellore. And
Including Dr. Sailo, sir.
Dr. Sailo. Yeah, that was really great. You people are doing great service.
I'm very
Thank you,
happy to
sir.
see Dr. Bobby also in the.
Yes, yes, yes.
Bobby is my colleague.
Yeah.
Thank you very much. We are very grateful to each of you. Thank you very much.
Thank you all.
Thank
Thank you. Thank the audience. Thank all the faculty. Madam who has given a wonderful lecture. Dr. Sailo, Dr. Cornerstone, and Dr. Rohit, Sujata ma'am. Thank you all.
Thank you very much.
Thank you.
Good
Thank
night. Good night. Thank you very much.
Good night.
जवळ जवळ